Our next session is Reimagining Public Engagement in Healthcare. Please welcome to the stage our speakers and session chair, Dr. Mark Davies, Chief Health Officer of IBM.
Just give people a few minutes to settle themselves down. Welcome everyone to this session entitled Reimagining Public Engagement in Healthcare. My name is Mark Davies. I'm the Chief Health Officer for IBM, and it gives me enormous pleasure to host this discussion over the next 30 minutes, mainly because this is a subject that, frankly, I think has actually come of age. In my career, I think about the kind of three big conversations around healthcare: how we transform providers, how we transform between providers, how we create whole systems and defragment our care systems, and thirdly, how we transform the interface between citizens and the service. And it feels like those first two conversations have almost completely crowded out the third conversation, and no more. If you listen to what people are saying at Confed, we have shifted the narrative from this being a sort of nice to have to something that actually is an operational imperative. You heard Matthew Taylor saying yesterday, calling for a reframing of the contracts with the public, calling for a shift, a meaningful shift from the rather patriarchal way that we've used as we've used care in the past. So what do we mean by citizen engagement? Perhaps a comment around language here. By public, we mean citizens, we mean patients, we mean the general public, we mean informal carers, etc. And by healthcare, we mean it in the broadest sense. So we're really just talking about the broadest care systems. So what do we mean by this? What do we mean by this concept around engagement? So very simply, we refer to it as the way that a citizen sees and transacts with the service, with the care service, and how the care service sees and transacts with an individual citizen. And inherent in that concept is two things. One is the public are not a homogeneous group, and therefore there's an opportunity to personalize and target. And secondly, this is fundamentally around participation. This is fundamentally around co-production, partnership, and a two-way process. And I'm completely delighted to be joined by two old friends to talk about this. One who comes professionally largely from the world of care provision, and one who comes from the other side of the equation, from community asset development at scale. So between the two of them, they're a personification of the interface that we're going to be exploring. That work? Yeah. Okay, so let me first introduce Ben Bridgewater. Ben is an ex-cardiac surgeon. He's an expert in informatics, the measurements around healthcare in general, and specifically around clinical processes. You may not know, but Ben Bridgewater was the brains behind the risk-adjusted measurement of mortality in cardiac surgery, which is internationally renowned. It's one of the things that the UK is really famous for, and is attributed to reducing the mortality in cardiac surgery by 50%. He continues to be an academic, and he's now the chief executive here in Manchester of a fantastic organisation called the Health Innovation Manchester, which serves the 3 million people residents in Manchester. Gemma Gilbert is the Director of Transformation for NHS Transformation Partners. If you don't know Gemma, you should spend some time to meet Gemma. So she has deep expertise in large-scale community asset development, engaging with diverse populations, and coalescing both healthcare, social care, and community groups into collective action. So she's led the London Homelessness Project. She's doing some major work around HIV. She leads on a number of pan-London projects around health equity, and I'm proud to say last year she was given an OBE for the work that she did leading a vaccination program for people who have street-based lives. So Ben, Gemma, very welcome. Gemma, do you mind if I start with you? Can I ask you just this really simple question of, like, why is this important?
So it's really important because at the moment we're throwing quite a lot of money after bad outcomes. So good money after bad outcomes. And when we sort of think about the way we think about patients, you know, we think about the inefficiencies in terms of them not accessing the service or them not attending the service or, you know, falling out of a pathway because it's a choice. But the reality is that for some individuals, they need a lot of different types of modes of access, support and choice in order to really engage in a service. So in a sense, with a small bit of investment, you can create new modes and ways of engaging with different people that will mean that they are accessing, they're not DNAing, they're not falling out of pathways, and the impact of that can be huge on their health. But the other thing we're missing is the asset base. So there is huge hidden value, and we saw some of that during COVID. So we saw the community humanitarian effort and the way that kept people well and going. So, you know, there is a mass of resource out there. The previous talk, if you were in the same room, was about the workforce demand challenge, you know, and sort of patient engagement isn't just about going out and listening. It's about saying, come in and help us get this right for you. And also, you know, let us see if you can also work in the service to help us get it right for more people. So there are real opportunities, I think, to use that asset in unique and new ways. Yeah. Brilliant.
And it's often said, isn't it, that patients and informal carers are the most valuable asset that we've got in our care system and the most underutilised. And it's an interesting shift, isn't there, from thinking about the public, us, as demand, and shifting it, the concept to resource. Ben, same question to you. For you, why is this whole issue around engagement so important?
So, I think that we're in a changing kind of dynamic here. So, Mark used the word paternalistic before, and there's no doubt that there's much of the medical profession, much of NHS culture was incredibly paternalistic, and I think that the professionals and organisations have some responsibility in that regard. I think also the public has been a little bit complicit in that over time, where certainly I did cardiac surgery for 25 years, and I've often felt that people were happy to be the recipients of whatever the NHS deemed appropriate to give them free at the point of care, rather than actually being more active in that. So I think we've gone from a place which was very paternalistic, and I think we then got ourselves into a place where the voice of the public was king, and that worried me a little bit, because if you have lived experience of a chronic disease, for example, that's incredibly important. But actually, it's only one facet into a conversation. And actually, what's also incredibly important is people who understand how to deliver services. And so what we need to do is bring those things together to a much more holistic, equitable conversation. We believe in our organisation that you should do innovation like you make software, where you have an agile, multidisciplinary team, facilitated by the appropriate Scrum Master, where everybody's voice is important. And actually, one of the voices in that is the voice of the public. One of the voices is the voice of the care provider, and so on and so forth. And so when we talk about reimagining public engagement and things we're trying to do, that's the kind of thing we're trying to pull off. I think it's fair to say we don't know how to do it properly yet, but that's where we're at the moment.
And Ben, just light that up for me, acknowledging that we don't know how to do it comprehensively and at scale yet. There are some really good examples of where that's worked. I know you've talked about some in Manchester. Do you want to just give me a couple of examples of where you think it's worked well and maybe why?
Yeah, there are some unbelievably good examples. We have some that I know about in my world. There's others, and I'm sure Gemma will tell you from her world. So fantastic examples. But the one thing these things have got in common is they're driven by highly capable individuals. And I don't think that's good enough anymore. I think what we need to be doing is working out how we can bottle that up and make everybody able to do this in that kind of way. We've got some good examples around engagement with the Pakistani community in Rochdale around cardiovascular disease, for example. Lots of good examples, but they're all a bit point sourcey rather than actually got this stuff properly bottled up, which is where we need to be. I'm going to give you one very specific example of things that I've learned in my career on this. So right early on, and I'm talking here about 1999, 2000, something like that, I started copying correspondence as a cardiac surgeon to the patients. I just sent them a copy of everything back. This didn't seem to be a massive thing to do, but it was quite pioneering at the time, and it was a complete disaster. Because what we then found out is that we'd write this letter back to the cardiologist, we send a copy to the GP, and then the patients would go into the GP to say, what does he mean? What does all this language mean? And it was a disaster, and we got all sorts of complaints from GPs. So what we did, we responded to that and said, okay, we need to have different language in the letter. So I started to write different language in the letter back to the cardiologist, which people understood, and we supported that with a kind of helpline, and we said to people, if you have any problem with this, please call in and do this kind of stuff. So this is an example of what I'm saying. We had a good idea, it didn't really work, but keep trying until you get it right.
Brilliant. Gemma, you must have hundreds of examples of things where you must be very proud of some things you've done, but sort of other examples that you've seen work well.
Yeah, I mean, in our organisation, Transformation Partners, we really do put co-production, engagement kind of at the heart of what we do. And I guess just to contrast that example and give another one in a slightly different sphere, but which might be of interest to you though, also Ben, one of my favourite examples was when we were working with London football clubs, and we identified that a lot of 40-plus male football fans were overweight, their cardiovascular risk scores were quite high, high levels of diabetes, and if you go along to a football match, there's a lot of pies and burgers and beer, and but it's also religion, it's a social thing, it's wonderful for well-being from a social perspective. So we got London football clubs to work with London football fans to design an intervention. And essentially what they created was a competition between football clubs to lose weight, to get fit, to get active, and we called it Fan Active. They trained alongside, so fans came together and they were trained by the coach from their football club that they loved, their religion. They met other fans, they got social connection, and we saw huge improvements in health outcomes, in huge reduction in cardiovascular risk and other things. The social connection was great. So, without that co-production and engagement and understanding what was meaningful to them to support behaviour changes, you just can't deliver effective preventative interventions unless they're in the context of someone's life. That was fully in the context of their lives, and the results were phenomenal.
Fantastic. And actually, one of the lessons from other industries, because healthcare, social care isn't the only kind of body that's trying to engage people. Yeah. There are lots of people out there that are trying to sell us stuff and trying to kind of engage us in different ways. And marketing and advertisers have known for years that they need to tailor messages, and they've known for years that they need to go to where people are. And it feels like we're just kind of waking up to this concept, meeting people where they start. And Jem, maybe just start with you, because one of the narratives that's true of this space is it tends to be talked about in terms of patient experience, in terms of outcomes, all of which are very important. But I talked about operational realities here. There are real operational benefits to this, and there are financial sustainability benefits for this. And in the current narrative around our care system, this feels that the pressures are so significant that we need to kind of starting to think about some of those. Can you unpack some of that for me?
Yeah, I mean, I think people will often sort of have this myth that it's the nice to have thing, or that it's like soft, bit cardigan, I guess, and but that's not the reality. I think one of the challenges is how you measure the impact often and how you attribute the impact, but there's some very clear examples I can give you, some very hard examples of how personalisation and real sort of peer-to-peer kind of working can support impact. So let me give you some of those. So let's think about HIV clinics. So as you know, HIV today, if you're on the right therapy, you can't pass it on. We had a HIV clinic in London that was running at a rate of a sort of achievement in terms of that stabilisation with their patients of about 65%. We put in a peer support worker, someone who understands what it feels like to have lived experience of living with the condition, who would be a follow-up supporter, phone caller person for the clinic. They increased the rate of stability of people on the therapies to, I think it was 97%. That is a huge increase. I'll give you one more, which I think is also really important, and I can see colleagues in the audience from Pathway Charity. Now, this is a combination of peer advocacy and support and some specialist input. But if you put a Pathway Inclusion Health team in your hospital, they've proved at St George's that for the inclusion health population going through that hospital, they can reduce A&E attendances by 66%. Because it's so personalised, it's addressing so many of their needs, the impact can be huge. But it requires that sort of depth of engagement. You know, that's probably the best news you'll hear about A&E, probably for even this coming winter. You know, the results can be stark. I think the National Association for National Academy for Social Prescribing, they did a study of 10,000 people receiving social prescribing interventions. These are all public engagement interventions in that they go to the holistic heart of what people want. They listen. They really kind of tailor services. And their results were that if you invest 4.5 million, it will return something like 11.7 million. So it's real value return. And as I said earlier, you know, not losing people from services is important. There's a genuine health cost down the chain when it comes to youth. There is a real kind of need to take that support and holding for some individuals very seriously.
My challenge might be we can't afford not to do this.
Yeah.
We can't afford to ignore this asset. But Ben, any kind of comments on this whole kind of efficiency, financial return issue?
So I'm about to commit healthcare heresy here, and
Good.
yeah. So you know the triple offer. What's that? Great outcomes, great experience, lower cost. I don't think that really serves us very well, because to deliver great outcomes, great experience, and lower cost, you probably need more money than we've got. So you need to make some choices here. And I worked in the digital world for a few years, and there's a big thing where you differentiate yourself as an organization. You're either operationally efficient, you're highly customer intimate, or you're a great product leader. And I think we need to be doing more thinking about that in there, and do really effective public engagement to actually tease out when being highly operationally efficient is the best thing for everybody, but be honest about it. And I'll give you an example. If I was to trip off this stage, going to greet an old friend in the audience and break my arm, I would want to be in and out of MFT by 4:30 today. I don't care whether they call me Ben or Benjamin. I don't care what the food's like. I don't care any of that stuff. I want operational efficiency. I want that to happen really, really fast. And that's good enough for me. But the more we can get into those sort of conversations about segmenting the population, segmenting the services, and having the right kind of approach with the right kind of channel in a way which is co-created, then I think we'll be in a better place.
Which speaks to what I was saying before around not treating everyone the same way and understanding what people's priorities are. So I love that. And just to say, I haven't got a license to practice anymore. So if you fall off the stage...
I'm on my own.
Yeah, you're on your own. You mentioned digital, Ben, so I want to continue on that theme. So clearly digital capability is an important component of this. It's not the whole component, but it is an important part. Do you want to just kind of explain to me why you think digital capability and digital transformation is an important part of this conversation?
Yeah, so can I commit more heresy? Is that okay? So
is everything going to be heretic?
I hate the expression learning healthcare system. I just do not like it. So, you know, Google doesn't advertise itself as a learning digital platform, do they? They just basically have stuff going on which has a whole bunch of data which they're smart about using to refine the products and services they provide. And that's where we need to be, because as I said at the opening, I don't think we know exactly how to do this stuff. And we can have the best idea in the world, and I take you back to my example about sharing the correspondence with the patients, and it doesn't work. So you need to be really humble. It may be the best idea you can possibly have, and I'm not knocking the idea, but you need to be humble that it may or may not give you the things that you want. But actually in a properly enabled digital system, which most places have to a lesser or greater extent now, you then need to be using that back-end data to actually understand this and continue to refine in that kind of way. So digital is key in that kind of stuff, understanding the effects of what you do and getting what you want and not getting what you don't want. And the second thing is, as Mark said, in terms of segmenting and micro-segmenting the population, that's exactly how retail works and retail tech works. We should be doing the same thing. You can't be doing that without great digital infrastructure. So digital is the heart of all of this. And I'll say one last thing. One of the things that really worries me, this is the thing that keeps me up at night when I'm not committing heresy in front of a lot of people, is actually how do you make sure that your innovation doesn't create inequalities, because most of the innovation we do creates inequalities. So we're really starting to think about that. And one of the big things in this is digital exclusion. So how can you walk to a digital world and recognize that actually digital exclusion is a real thing and address that in a systematic kind of way? But I would argue quite strongly you can't do that unless you have digital approaches for dealing with digital exclusion by understanding your population and then making sure you deliver multi-channel solutions in that kind of way. And you can't do that unless you have decent engagement and you co-create new solutions.
And one of the really strange conversations we have, which always baffled me, is because of the very real risks of digital exclusion, then we don't do anything. And there's a kind of weird concept that we do the same thing for everybody, and we're actually saying the complete opposite. We might be able to, with digital front doors, with kind of digital ways, with automation, we may be able to create headroom in terms of our resources to throw more resources into those parts of the community that perhaps need more outreach. Any comments? You've done a lot of work around communities where they need bespoke approaches and a lot more co-produced approaches. What kind of works and what
Yeah,
doesn't?
I mean, I think Ben started in the right place. You can't stop the progress of digital. It has real capabilities for us that we need, but you do need to also then temper that in terms of identifying inequalities. In Transformation Partners, we support a London hosted digital solution around mental health and well-being. Interestingly, the insights on that show real equity amongst ethnicity across London, which was quite surprising. You know, you often see a very mixed profile of access to NHS services, but this solution didn't show that difference. There were some gender differences, though, and they were kind of interesting. But I think, yeah, I mean, I think the real key is with any development in health, we've really got to start with the people we think might be excluded first and think about if we can design something for them that works, then we will get it right for everybody. So don't stop the progress of digital development, but actually think about that exclusionary factor, put some funding and thought around it. I think that's where things get left behind. We don't sort of invest at the same time as we invest in that digital development in the alternative solutions for beyond that closed door. And I think those alternative solutions, you know, are very much kind of about working with those populations, designing something that works for them, and in some cases providing that peer support and advocacy that we see from people like Groundswell, you know, who take people from our sleeping population to a practice and help them register and advocate for them. So yeah. Yeah.
And tell me something, I don't want to kind of sort of focus on the negative here, but where does it go badly wrong? You know, what do people do? And you must come across projects all the time and you just think, oh no. You know, what are the kind of big mistakes? Someone on the slide has just made the comments around the dangers of language, and there are some elements of the population that feel alienated by the word citizen, which is a really good point. So what are some of the things that you kind of you slap your hand on your head when you see them? What are the big mistakes?
The big mistakes. I think that some of the big mistakes are really just about that change. I mean, if we think about the primary care front door change, I mean, I was involved in. Years ago in 2011, I ran a GP innovation scheme and worked with a group who were developing the e-consent model at the time. And I sometimes sit back from that and go, okay, what was the negative consequence of that for individuals as well? I think the thing that I always slap my head against is that, you know, particularly for the most vulnerable populations, the inclusion groups in society, about 25% of them aren't even registered. So they're not on our systems, they're not on our digital systems, they're not on our data systems, they're not appearing anywhere. And so we have to always challenge ourselves to look beyond and do seeking and finding, go to temporary accommodation, find out where families are living in temporary accommodation, because they may not be even involved and engaged in the system. So it's great to create these solutions, but there's a gap of people who just aren't even part of the conversation. But
Ben, I wanted to ask you, I mean, you, in your career, you've had exposure to other industries and you've seen, what do you think are the big lessons that we could be stealing or applying from other industries into the care sector?
So when I was a cardiac surgeon, I worked with a whole bunch of people who were highly gifted and technically brilliant, and I wasn't highly gifted and technically brilliant. But I had a method, and I stuck religiously to that method, and that served, I think, my patients well. I think it served me well, and I've taken that through my life in terms of what we do. So we're really thinking hard about innovation method, and I don't think people think hard enough about this. So when we talk about pathways, we have a process, and we call it understand, reimagine, implement. And our experiences of when things go wrong is people jump straight into a reimagine and spend 20 seconds on that, and they get into implement and they're surprised when it doesn't work. So my kind of big lesson is actually take that understand phase really, really seriously, and make sure you've got a method for that. Make sure you bring in digital approaches, experience approaches, voices, stories, all of those kind of things. Go deep in understand, and then use those insights from the understand phase to proper deep co-creation reimagine, and actually front load this process. More haste, less speed in that space, I think. And then finally, when you implement, recognize it may work, but it might not work, and be humble about that.
Fantastic. We've got about 5 minutes, so I want to throw it open to the audience. So if anyone's got a question, if they could put, I can't see you, so if you put your hand up so we can get a roving mic to you, that would be super. Who's going to be brave and ask the first question? We've got an audience, people who've completely cracked the challenges around citizen engagement. This is fantastic. There we go. Brilliant. Would you mind just introducing yourself and ask a question? The lady just is right next to you. Thank you. Thank you.
Thank you. My name's Debbie. I'm Patient Public Involvement Lead for the Innovation Agency, one of the AHSNs. I lead a group of Heart Heroes, and we engage with members of the public. Our Heart Heroes are volunteers. They're out in Preston today. We'll be in Mosque in Burnley on Sunday. But it's a different way of engaging with the public to do blood pressure, pulse checks, part of our CVD agenda, but we use that as a way of engaging with them, building trust, because we keep going back. It's not a tick box where we do it, leave them, and I think that's really important in our so my question is, how can we replicate that and do other things to get healthcare to the communities rather than expecting them to come to us, which they often don't?
Fantastic question. Jem?
Yeah, no, it just struck me as you were talking about, the thing I absolutely love about this sort of engagement work is the relationships that you build and how they enrich your understanding. And what we really need are health leaders who are curious about that and want to go out and connect with individuals and communities and learn through their stories. So, I think it's absolutely right that we need to get more out to people, but also we need to bring them into the conversation, at every level in terms of that policy and design and through designing the implementation. One of my favourite programmes is the one Getting to Zero HIV in London, because, you walk into the board, it doesn't feel like a board, it feels like a family of co-production, and you've got the VCSCs, you've got the community voices, you've got the clinicians, we know each other so well, we go out socialise together, you're kind of sharing all of the funding budget decisions, you're sharing everything together and you're co-designing. So there's something really important in that about not just seeing them as passive recipients of a service, but actually making them part of the team, part of the conversation. And that should be widespread practice for all leaders across everything you're doing, is actually, using them as part of the team and the resource.
Fantastic.
Yeah.
And I might just add, I think one of the really critical things is to imagine one of your audience is the chief financial officer of an integrated care system, and how you look at your evaluation in such a way that speaks a narrative to to that, or indeed an operational narrative. And the days of just seeing something on, sadly, from a operational perspective or an experience perspective, I think no longer is enough. Ben, do you want to comment?
No, I think it's a good example. My comment would be, probably if you go around the room, we'll have a whole bunch of great examples of stuff. But what we haven't properly got is systemized approaches to that, which actually maximise the impact, and that's where we need to get to.
Fantastic. Do we have another question? Just one at the front here. Amelie.
Hello. Oh, sorry, that's loud. Amelie from Salonis. Thank you so much, first of all, for sharing your experience. It's been very interesting. This is quite an open-ended question, but I'd love to know, what are you really excited about that you're working on in the next 12 months?
Ben, do you want to kick off?
Vaccine rollout, right? So in Greater Manchester, we rolled the vaccine out, and I don't know the numbers, but I won't be far wrong with what I say. We probably had a vaccine penetration rate of about 90-something% to the population. But we systematically managed to give the vaccine to all the people who needed it the least, and systematically not managed to give it to all the people who needed it the most. We've measured that through our back-end data assets, and actually we're going to do something about that. So let's properly understand what are all the barriers, and the barriers will be different in different communities, but let's start to work in ways which actually address that, so we can actually address better outcomes in that kind of way. And actually let's not just learn from healthcare in that, but let's learn from retail tech, particularly about how you micro-segment the population, how you nuance messages, how you use the right kind of champions. We had a great example before about football clubs and stuff, but how do we do that in a different kind of way? And let's keep trying to do that until we get it right. That's what I'm most excited about.
Brilliant. Jen?
Oh, I love that question, because I love talking about the exciting things. So yeah, we're kind of about to launch some work around a thing called a community chest. So novelly based on the Monopoly board. What we've identified is that, you know, we've put a lot of investment into social prescribing enablers and teams within primary care, as have local government with community champions and things like that. One of the kind of elephants in the room is that our VCSE sector community organisations are really struggling with the cost of living crisis and everything else that everyone else is, but then perhaps more vulnerable to that. So we haven't addressed the situation of how we fund. So the idea of a community chest is that you can create a local shared investment innovation fund that is co-produced and committed with communities, where you can bring health and local government money together, where you can also crowdsource funding from other types of parties, you know, be it hospital charities or local employers thinking about social value and sustainability, and really start to kind of create a fund that addresses local community need, not just a nice to have priority from over here, but actually try and harness what we can for those communities and deliver it in partnership with them. So really excited about that. It was developed with North East London ICS, but we're hoping that it gives people an inspiration and a concept that could be used elsewhere. You don't have to call it a community chest though. I just like it.
Brilliant. Thanks so much. We're really tragically out of time. It's been a brilliant conversation. It's been a real privilege listening to you talking. Just before we finish, very briefly, I want you to give the audience one thing that you want them to take away from everything you've said. Ben?
Just do it, accept it might not work, and then do it again.
Brilliant. Jen?
Basically, see patient engagement as bringing people in, even to the extent of making them part of your workforce, because that's where the really high value impacts will be seen.
Fantastic. Well. Thank you so much. Thank you for joining us. Please fill out the evaluation on the Slido form, and I'd be grateful if you'd thank our two panellists in the usual way.